powder over the child. We've discouraged use of talcum powder because the talc particles do go into the baby's lungs or into the child's lungs and cause problems. So we now use cornstarch, and it's usually poured in our hands, not near the baby's lungs or near the baby, and then you can put it on your baby. Acute respiratory distress syndrome. This can happen anytime the child loses its ability to exchange oxygen. It's characterized as respiratory distress, hypoxia within 72 hours after serious injury or surgery in a person with previously normal lungs. If you look on page 781 in your Wong's book, it'll show you the pathophysiology of how it gets to be this bad. Treatment is ventilation to secure the clear airway. Prognosis, the precipitating disorder, determines the outcomes. Nursing care is to monitor cardiac output. The perfusion, what's perfusion? That's the exchange of oxygen in those lungs. Fluid and electrolyte balance. You monitor their I&O, their respiratory status, and their O2. And this is an RSD video to show you exactly what they do. It's respiratory distress syndrome in the newborns. So if you put that up on your URL, you'll be able to see that. Inhalation injury, smoke and carbon monoxide. Severity depends on the nature of the substance, the environment, and the duration of the contact. Is it a local injury or a systemic injury? Therapeutic management, you do symptoms, receiving humidified O2, hyperbaric chambers for CO2. When they have carbon monoxide or carbon dioxide, you can use CO2. You can use the hyperbaric chamber. And that is just a chamber with 100% oxygen in it. Develop RDS, and they may need intubation. And burns can cause nasopharyngeal swelling. Passive smoking, the scope of the problem. For a child that has asthma, this is not the thing to do. It's on your clothes if you're a parent that smokes. It's on the drapes. It's all over the place. Even if you go outside and smoke, that child's getting secondhand smoke from your clothes and when you come back in. The impact's greatest on children. Why? Their bronchioles, everything about them is small. Their lungs are little, so they're getting adult doses of irritants in their lungs. The nursing considerations. We need to talk about educating our parents. If they're smokers, keep this far away from children with asthma. It's not the thing to do. Smoking is to be discouraged too, and we can help them by teaching them and telling them about all the available programs if they want to stop smoking. Vital signs. We want to watch their I&O, their pulmonary status, trach if upper airway is affected, nasotracheal if lower airway is affected. Asthma. It's chronic inflammation disorder of the airways. Bronchial hyperresponsiveness. It's episodic. Doesn't happen all the time. You don't live with it 24/7. It's limited airflow or obstruction that reverses spontaneously or with treatment. Etiology and pathophysiology. Sometimes many of these children outgrow it. And sometimes they keep it and it becomes worse for them. Inflammation is the contributing factor, bronchospasms, and obstruction. Trapped air causes increased volumes to the lungs. It's asthma severity classification in children of 5 years and older. Step 1 is mild to intermittent asthma. Step 2 is mild and persistent asthma. Step 3 is moderate persistent asthma. Step 4 is severe persistent asthma. And then clinical features of each classifications. Diagnostic evaluation is dyspnea. What is dyspnea? Wheezing and coughing. Therapeutic management is to look for the signs and symptoms of respiratory arrest, which are shortness of breath, air movement in the chest is to absent breath sounds, or a rise in respiratory rate. This is a serious, serious matter. Pulmonary function tests can tell you how affected the person with asthma is. And the nursing considerations are to maintain normal activity level and normal respiratory function. Drug therapy for asthma. Long-term control medications. Quick relief medications. Metered dose inhalers. We've all seen those little tubes that the children learn to breathe. They put the medicine in it and they breathe it out of the chamber. Cromolyn sodium, albuterol, metoprolol, and terbutaline. Long-term bronchodilators, such as salmeterol or Ceravent. Theophylline, they monitor the serum levels on this. Leukotriene modifiers and others. And here's a picture of the mom with that inhaler, that metered dose inhaler. See that chamber? That's where the medication goes and then the child breathes it out. Inhales it. Asthma interventions. Exercise. Chest physical therapy, that's CPT. Remember when I told you on the preemies we use the nipple? And then you get the little percussors. Sometimes it's a toothbrush. Wrapped up the toothbrush, an electric toothbrush. You wrap it up with gauze and tape, and you percuss the lungs with that. Hyposensitization. And you look at the prognosis. Status asthmaticus. Respiratory distress continues despite vigorous therapeutic measures. It's an emergency situation. You want epinephrine, sub-Q, concurrent infection in some cases, and therapeutic intervention.